Yeah.
Bhavin, can I say to you, you don't look a minute older than you were at the start.
But
Okay.
likewise,
So,
I can say
yeah.
the same about you.
Okay, we are live now. So, good evening, everyone. Today's MDM is really special to all of us because it marks 2 years of this journey of thinking together and learning together. And this platform began with a simple belief that no single discipline owns an ILD diagnosis. And that you would have seen with bickering of our Bhavin sir and Athol Wells sir, always like who is right and who is wrong. But it is a part of learning, isn't it? So it grew out of a personal frustration with a siloed care that and desire to intellectual honesty. Over these 2 years, through our like we published one article, and now I'm going to present the audit. We are going to try to show that how MDM don't just agree, but we correct and refine the diagnosis too, and especially when the uncertainty is the greatest. So this MDM is actually a community, and rather Prabhu Desai sir says it is like a family. He miss us. If he missed one meeting, he messages me that he missed it. So it's like a community, or you can say a family, that is because of the faculty who shows up every time. My sincere thanks to Bhavin sir, Vimal Raj sir, Aparna, Rajan sir, Murli Mohan sir, Prabhu Desai sir, Mithun, who is not present today because of conference, Ritu madam and Sharda. And above all, our Professor Athol Wells. Thank you for all your guidance and unwavering support throughout both the years. Thank you, Sonia, also, because she also joined. Because as we can see, like-minded people come and join us. A special thank mentions for Lupin people, Mr. Subodh and Alchem, Mr. Arun, for the quiet. As you can see, our brand doesn't carry any pharmaceutical company's name, but these are the two companies provides us brochure all the time, and the other company provides me the link without any reminders, and it truly means a lot to me because that makes my life easier for making it happen every second week. And as we move into our third year, my commitment remains unchanged, as with our all the faculties, to keep this platform honest, rigorous, and patient centered. So with that, let us start the first. I will be presenting the audit of last 1 year. It does not include the article which we have published. It is after that. So this is as we what we have today is not just an MDM, but a shared belief that thoughtful collaboration can change the care. And this is what we achieved in last 2 years. It is not only case discussion. This many brands and this many things were born out of just this discussion. So it is an amazing thing that we have made so many things out of this, and all of them trace their roots back to one thing, that this MDM and the people in this particular call or room, whatever you say, I believe it is room only. And when the intent, what I believe is, when the intent is right, the impact follows, and that we can see by our MDM. Our panel members, as you can see, all greatest of the great in their field. And thank you so much for being so kind to come and share your wisdom every time. A big thanks to the entire team of ours. I would not name it, you people all know them. And this was our article which recently came in December 2025 in BMJ. And why this is important is, this is first time in the world somebody has done multinational MDM, and it is in country which is as heterogeneous as India, and it worked by seeing the findings that 23% of the ILD diagnoses were revised after virtual MDT. CT concordance was with kappa Cohen scale of 0.66, and histopathology concordance was 0.86. For HP subset, and highest reclassification actually and surprisingly happened between HP and sarcoidosis, and we'll come to know about this year's data also. And highest stability was found both radiology and histopathology in OP, CTD, ILD, and UIP pattern. And that was the data of last year. Why this audit? So BMJ open publication validated the MDT process of 127 cases. That was up to May 2025. After that, we want to assess the diagnostic stability beyond publication and audit, readdress real world consistency and refinement. So after May, we discussed around 95 to 96 cases, and CT concordance was assessed in 96 cases. Histopathology concordance was assessed in 21 cases. So 21 only underwent biopsy. That is almost one third of the total case. And final MDT diagnosis concordance was assessed in 95 cases. This is the baseline demographics, and the low saturation was present in 19%, while 82 people presented with normal saturation. And if you want to see how the ILD fares through the classification, so others were again the highest, followed by CTD ILD, HP, sarcoid, UIP, and idiopathic NSIP, OP, IPF. This is the distribution of ILD cases. 49% were female, while 51% were male in our this particular 96 cases. What we tried to find out was radiological pattern, whether it matches in the pre and post, histopathological pattern, and overall diagnosis. The amber color shows the meaningful reclassification. So there were 12 cases of HP. Out of that, 8 remained HP after discussion. 2 went into others. Those others were PPFE and BIP pattern because of some other reason, CTD ILD in that case. And sarcoidosis were around 11. 7 were reclassified as sarcoidosis. 2 were, one was silicosis, one was mixed pattern, and it was not termed sarcoidosis after discussion. Most of other things were well pretty much same, nothing new. So which highlights that the diagnostic stability was highest for NSIP, CTD, UIP, while the greatest reclassification again occurred in HP and sarcoid, highlighting where virtual MDM review adds maximum value. And CP pattern concordance was 0.73 this time, 0.66 last year. In histopathology, as you can see, HP was total 5 cases. 1 was classified as UIP after biopsy. Sarcoidosis, 5 cases, 5 were sarcoid only. And UIP and other things were also pretty much same. So what this says is histopathological agreement was very high this time after virtual MDD, and with near complete stability for granulomatous disease like sarcoid, UIP, and others. Reclassification is limited and mainly confined to HP. So here I would like to invite comment afterwards that maybe in India we tend to overdiagnose HP on radiology, and after biopsy maybe it is reclassified. However, I might be wrong. That is my interpretation. And here 0.749 was the Cohen's kappa value, which was 0.651. It was 0.86 for HP last year. So excellent agreement for granulomatous disease and UIP, as I showed in 5 out of 5. Now overall diagnosis, this was for radiology and CT, HP. The overall diagnosis concordance was around 95 cases were discussed, unchanged diagnosis in 71, and we changed diagnosis in around 24, which is coming around 23% of the cases. So, 21% of the cases. So we have reclassified here again, between 20 to 25% of the cases were reclassified. And most diagnostic shifts happen in HP, UIP, and IPF spectrum. And that tells us, reflects us that MDT driven refinement rather than inconsistency. We don't say that it was wrong diagnosis or anything, but we refined the diagnosis. So last time we discussed with Professor Athol Wells that how can we improve this, because we are just collecting HP concordance and CT concordance and overall concordance. So sir suggested us that what we have to do is we have to improve the precision rather than only radiology and pathology. So we have to start doing a pattern. When we are commenting about the diagnosis, we have to write what is the pattern, and we have to integrate the behavior, how the disease is going to, whether over time, whether it is going to be progressive, stable, or it's going to worsen very fast. And we have to definitely start mentioning that confidence of diagnosis, like how much confident you are. If I'm saying UIP, whether I am having 70% confidence or 80% confidence, that has to be done from this year onwards, and that is what we see. So we would like to incorporate pattern behavior, add confidence of diagnosis, and static labels to dynamic disease. Like rather than putting OP, HP, I would say that whether the disease is supposed to be improving or worsening over a period of time. And with that, I would like to end and invite anybody wants to say thank you for showing up, thank you for believing, and this journey continues together till we all are here. Thank you. I'll stop sharing my screen and maybe we can invite comments. Yeah. Yeah, please, Professor Ethelwell.
Just very briefly, since I was guilty of introducing confidence, I will say a word or two on that. I think there are two things to say about that. Firstly, if you're high confidence, you will also get greater observer agreement. And I think that confidence of a diagnosis is a neat way of saying and knowing it will be a surrogate for consistency across groups. The second thing is I wouldn't go 80% versus 70%, but broad bands, and we numerate them to make sense of how we actually think of diagnosis. So you've got a category where you have to say you're there. And I don't think it's ever 100%. And we numerate that as above 90. But what we're really saying is it's in that category where we don't have uneasiness. Then we have a group, we're close to it. But by the way, we're not sure. And that's 70 to 90. That's a confident working diagnosis. Then we have a tentative working diagnosis. I can say this diagnosis is more likely than not, but I certainly can't go much beyond that. Then we have, I think, a group of patients where you can't make a first choice diagnosis above 50%, but the meeting should state the major differentials. And the plus in that is you've got honesty about diagnostic precision. If it's 50 to 70% likely, you are already saying, we think we're making this diagnosis, but there's actually a significant chance we're going to have to revise it. And so you're prospectively saying that a change in diagnosis is not a mistake made by the group. It's an acknowledgement that you can't run to yes, no in a clunky way, given the real world. So those were the things that informed what I said about that.
Yes. Murli Mohan sir, Bhavin sir, anybody wants to say?
Just a word of caution. This does not represent the true. Sorry, this does not represent the true distribution of. Sorry, there was some feedback.
Professor Varis, if you can mute, yeah.
Can I? Okay.
Yeah, so I was saying this does not represent the true distribution of cases as in a registry. These are difficult cases brought to the group, either because of difficulty in diagnosis or difficulty in management. So that's just a word of caution I want to add.
Yes, sir.
I just want to tell, since Atharvales is so consistent over here in this meeting, and we have from Sri Lanka and some other countries also, Pan India, should we remove that word and do something else?
But the cases, actually, I thought about it, and what Rajan sir initially told me, or somebody suggested that the cases which we discuss are from India.
Okay.
So that was the reason that we didn't change it.
Okay.
You know, all I can say is that, Ashmita, you're a force of nature. Because I think without you, this wouldn't happen. And, you know, it's such a force that you're such a force that the radiologists have to divide into three because we can barely keep up. So once in 6 weeks is when we can find our footing after we've been blown away by.
No, but we are very happy because we got the best of the people, sir. Because other radiology, as Rajan sir said, I think Rajan sir also should say his remarks and then we can go, because he told that radiology is the backbone of ILD diagnosis. What do you say, Dr.
Good you all
Sonia?
acknowledge that, because I mean it is obvious.
Oh, that is so bad. That's so bad.
But to add, you know, that everybody's been there. I know that you may be the force, but Sujit was the backbone without whom this wouldn't happen as well, because you need 2-3 people to glue things together. And it's wonderful. It's great fun. Yeah.
Thank you.
Now, I just like to say that I think I echo what a lot of people have said. I also feel that the coordination is the hardest. Athol, can you mute yourself because there's some echo coming from your speaker? Sorry. Yeah. There is a phenomenal requirement on coordination, and I know that it's not easy. I mean, everyone has great ideas here, I'm sure, but actually getting down to doing it and consistently is what I have to give credit to Asmita for. And she's really ensured everyone's at the table and almost every fortnight. So we look forward to it.
Yes,
Whether we call it Pan India or Pan Global, Pan Universe, whatever you want, it doesn't make a difference as long as everyone's here with the same
yes,
energy and we all know what we are here for. That's
yes.
all.
Just a couple of quick comments. Yes, as Meeta, you've been a huge force, which leaves me relieved that this is an online meeting and we're not meeting face to face. Bhavin, I think you're being modest because I know you happen to think that radiology isn't the backbone, it's the whole body of ILD diagnosis. I have just one other comment, just thinking it through. I like that UIP is thought of as a discrete biologic entity, even if other forms of ILD evolved to it. And it does fit. But if you were thinking about communicating this worldwide, I do really wonder about UIP-HP within an HP group, UIP-CTD within a CTD group, and then when we have idiopathic UIP, we are talking about UIP-IPF if you want to be tautologists or you just say IPF. This is really marrying up how people around the world have processed disease, but trying to get in there the importance of the UIP subset. Then you don't get into some confusion that either you've got HP or you're calling it UIP and no longer including the HP bit. And so it's more a matter of balance. People have been obsessed with diagnostic splitting without sufficient recognition of how the diagnosis equates to disease behavior. That's a suggested compromise.
Okay. Anyone wants to say, or we'll move on to?
Yeah, one point I would like to add. Histopathology, always I find that, I mean, the
It's
entire
less.
whole slide is not being shared. We are interpreting based on the images that are shared to us. So we really do not know what is happening with the other part of what is there in the other part of the slide.
Yeah, we'll keep that in mind. Anybody, Sonia, you want to say something, or we'll move on to the
I
cases?
just want to thank you. Sorry, came back from a vacation and I'm sick. Just wanted to thank you for including me because I'm learning so much from this MDT. So really appreciate your including me.
We want to say you thank you. We want to say thank you to everybody who is there. And Amila, are you there? You want to say something because you were also equally part of this meeting? I'm not sure.
Hi, I think I'm also not feeling very well these days, but anyway, my voice is down. But thank you so much for kind of including me as well. And I've been really enjoying this and learning a lot and contributing, I mean, as much as I can. And I think it's a real learning experience. And we all change our practice of ILD, especially I think in our part of the country and our part of the world actually, because that we don't have the facilities as the Europe and other developed countries. So I think we are slowly implementing changes in our part of the world. And I think this is one of the learning platform for everybody of us. And thank you so much. And I kind of wish all of you to kind of proceed with this for so many years to come. And thank you so much and congratulations.
Thank you. We have all the presenters of last meeting. Anybody wants to say? Otherwise, I'll start discussing the case. You can unmute and say if you want to say something. Mostly, we discuss only clinical things. So if not, then I will start sharing my screen.
I'm going to give a special shout out to Dr. Lakshmikant Yenge, who's constantly there giving messages from the background. Dr. Tridib, who's one of the regular attenders, and Dr. Shobha and Dr. Prakar, who regularly present cases. So thanks to all.
Yeah, I actually asked all of them personally to come. Shobha madam is in Hyderabad for ERA, so she could not join, but
She's
other
logged in.
she has? Oh, wow. Thank you. Thank you for that. Yeah. So we will start with the first case, and Marin will present on my behalf. Yeah. Marin?
Yes, sir. Good evening, everyone. So this is a 63-year-old male. He's a non-smoker. He's from Kerala. He's a retired engineer who presented to us with dry cough for the last 10 to 15 years, which was associated with seasonal exacerbation, and dyspnea for the last 1 year. He has history of exposure to cement dust. His vitals were stable. Local examination was normal. Respiratory auscultation revealed bilateral basal velcro crepitations. His routine blood workup was well within the normal range. RA factor, anti-CCP, ANA by IF, ACE were all negative. Serum calcium was 9.51. ESR and CRP were elevated, 3.7 and 41. KL6 was 999. The cutoff is 650 here. ANA profile was borderline positive for RNP. Myositis profile again was borderline positive for SAE and PL12. Lung function testing showed moderate restriction, FVC of 55% and DLCO of 39%. KCO was 76. 6-minute walk test do not show significant desaturation.
I think Aparna, if you can share your screen here. Mithun is not there. So Sonia, you think PL12 of 16 was strongly positive? No, right?
No, I think that that's pretty borderline. And I think
Okay.
that you would have to have a little bit more to make you, to convince you that that was a real number, that was a real.
Sure. Yeah, Aparna.
Yeah, we have two CTs. One is from September 2025 and the other one is earlier this year, January 2026. There is not much change in the fibrosis. So there is fibrosing ILD, as we can see, subpleural predominant reticulations, focal small areas of honeycombing, architectural distortion that is there, and little more in the bases also. So basal and subpleural predominant fibrosing ILD and few focal areas of honeycombing. So I would kind of call it like a probable UIP pattern. The other things that I want to highlight is there is one nodule here in the left upper lobe which has slightly spiculated kind of margins, which is almost similar in size. There is one small focal area of eccentric, I'll just zoom it up, focal area of eccentric cavitation also within that nodule. It's around 12 millimeters in maximum dimension. Other than that, so if we look at the mediastinal window, there are small nodes which are very borderline, around 10 to 11 millimeter, and I'm presuming them to be like reactive nodes. Main pulmonary artery is not dilated, no RARV dilatation. In the abdomen, there is some volume redistribution in the liver. So I would just get some scans, ultrasound to see if there's any chronic liver disease. Yes, chronic liver disease. So the
my doubt was like because he had cement exposure, no? Even the outside doctor who referred to me also suspected whether it is chronic HP or UIP. That was the reason we kept this case.
Okay.
So with that in mind, because he was a civil engineer and entire life exposed to cement dust. Now I'm not seeing civil engineer usually coming to me and it's not very commonly seen. But should we put that particular differential as a first, or you feel UIP?
Yeah, I was thinking cement would cause something like silicosis type of thing. I'm not very sure. That is what in my mind I was thinking. So I thought it was not looking like, yeah. So I didn't think it was looking like that. Hypersensitivity, again, it is not an organic material, isn't it? And the appearance is also not typical for hypersensitivity, is what I'm thinking.
Sure.
But I'm really concerned about that nodule in the left upper lobe. whether we should do a PET CT and whether we should think
This was a
about
PET
biopsy.
only. I think somebody suggested that PET, and we did, I think.
Yeah, so I saw that it is a PET. That was what I was going to say. And but it says it's this gallium-68 FAPI PET, which I don't have much experience with this PET, but I just looked up saying that it can identify the fibrosis part. So maybe there is some peripheral. I'm not very sure. I don't know what was reported on it. But for the nodule per se, maybe there is some uptake, but for the nodule, maybe the FDG PET would have been a better choice to look for it. And if it is positive, I think we should biopsy it. Although it hasn't changed much, but the follow-up duration is only 3-4 months.
Sure. Yeah, if you stop sharing, yeah. Yes, Professor Wells, you wanted to say.
I'd just like to draw you out on one question, because you said probable UIP and described honeycombing. And I have to say, I can't see clearly enough. You've got larger views than I could see on the screen. But I had the sense what you were calling honeycombing was, rather than rows of cysts, was isolated. So I think I would start by asking you if there's traction. Because if you're calling UIP on the scan as a definite, with honeycombing, that's a very different scenario from saying it's this rather non-specific entity called probable UIP.
Yes, it was very focal areas. That was the reason. Yeah.
So I think if you followed the sections, you'd probably find you were looking at isolated airways that were dilated. The only point I'm making here is we've got this mantra that probable UIP is UIP, and I'm afraid it's terribly misleading. It was developed in a group of patients with high risk for IPF. The prevalence of IPF vastly higher if you're over 65 and if you're a male and a former smoker, vastly higher than NSIP, probably 10 to 1. So if you have a non-specific appearance that could be either, sure, in that group, that scan will go with having UIP. But the moment you are not in that completely classic group, probable UIP, I suspect, is rather non-specific. And I will tell you, without boring you with series, that there's a lot of support for that actually in HP, in some of the other settings of probable UIP. So can I just ask you in the end, are you saying you think there's definite honeycombing and not traction?
Yes, sir. I think most of it may be traction, but maybe there are very small focal areas alone of the honeycombing. That is why I didn't want to call it as a definite UIP. I agree with you. Maybe it's more of traction.
All I will say is that in the large Adam-Gonsoy series, the cut point for survival in CTD in HP and an unclassifiable was presence of honey. It wasn't probable UIP. Huge series.
So Aparna, you do feel
Yes.
this is honeycombing, right?
Yes, sir, but very small focal areas. Most of it may be like traction bronchiectasis, but here and there are some clusters of cysts which I thought was like focal honeycombings.
I'm only making a thing about this because you've got stability on the scan over a period of time. It's
Yes.
not behaving like UIP in that sense.
It's only 3 months, 3-4 months, the duration of follow-up. Yes.
Yeah. You're right. Actually, patient was referred for PET CT and biopsy only, Aparna, and then FAPI PET was done complementary. We did a proper PET CT also. So those results I will just try to see. I didn't pay attention on that left upper lobe nodule. I'll definitely go and recheck about that. And yes, you are right that FAPI-PET is for fibrosis scoring. He was started on nintedanib from outside and he could not tolerate, so switched over to pirfenidone, which he is presently on. And the reason we are discussing this case is about um because this PL12 and SAE1 was positive without any clinical features of CTD or myositis. So because rheumatology is not there, mostly we will just cancel that. So you don't think that CTD ILD, right? By features, it doesn't match with CTD
No,
ILD.
no.
And then could this be fibrotic HP or non-specific autoantibody positivity? It doesn't match. So anything to be added immunomodulators, because if the panel feels it is a confident diagnosis of UIP, then only antifibrotic will do. But if we feel that it HP, then should I add any immunomodulators? That was the reason we put in a discussion. And somebody suggested biopsy also. The nodule is too small. Now, who will do biopsy from there? It's like very difficult unless we do some guided lung point or something like that, right?
How large is the nodule, Aparna?
12
11,
millimeters.
yeah.
12
12
millimeter.
millimeters, Bhavin does it very comfortably, Asmita.
Yeah, it
Yeah,
is
we don't have
doable
Bhavin, sir.
only.
Yeah, okay.
It's doable, but it's like there may be a slightly higher risk of pneumothorax or something, but it's
Mhm.
doable. Yeah.
Sure.
Could try a radial probebus, isn't it, Dr. Asmita?
Yes, sir. Yes, sir.
I think I would be hesitant to start an immunosuppressant until you know that that's not a malignancy, just because I think that although clearly the exposure time is going to be small, I think that from a sort of a patient perspective, it would be disturbing if they'd been started on an immunosuppressant before
Okay.
they had that diagnosis.
Okay.
Madam, a BAL would be useful to find out whether immunosuppression, seeing the lymphocytes, etc.
I think so.
Simple
I'm not
BAL,
sure,
not BAL.
Philip. I think I would focus on that left upper lobe nodule first,
Yes, sir.
and then if that's negative, maybe a BAL. You're right.
Okay.
And if there's a lot of lymphocytosis, look at a steroid trial, maybe.
Yes. So
You could
presently
probably do
he's
both
doing,
at the same sitting, isn't it?
can be done. Yeah, BAL is not
But
like we don't have to.
that's if you do radial EBUS, which we don't do. We would send to Bhavin for a CT biopsy. We won't even think twice about that.
Yeah.
Yeah, just as an aside, a civil engineer may still have HP not due to the cement, but they use a lot of other stuff in the construction. For example, in India, the cement columns, they wrap straw around it and they soak it. So you can get moldy hay from that, which will give you something like a farmer's lung. Not that I'm saying this is HP. I'm just, we don't need to invoke cement exposure. There are other
Yes.
causes.
Yes, sir. Yes, Professor Wells.
Just to plant my flag, I favor IPF as the diagnosis here, and I actually think you've got a two-hit pathway here. You don't have to have the exposures causing HP. All of the epidemiology for IPF is all sorts of dusts of various kinds, former smoking. And I actually think, in spite of going on about probable UIP, I think this is likely to be IPF. I have a question from Sonia, actually. I get driven mad by these marginal rises and teters. I just view them as something that you take with a pinch of salt. There's a normal range. Bit of immune overactivity will shift some teters above a normal range. We get this quite a lot in this meeting. You get this tsunami of minimal increases in mutually exclusive autoantibodies. And Sonia, you know far more about this issue.
So a lot of it has to do with the method that's used for doing the titering. And there's going to be a paper coming out shortly in CHEST that looks at a comparison of two types of methods for detecting the at least antisynthetase antibodies. And so I think that part of the problem is that some of the line blots are more likely to have false positives than the more immunoprecipitation associated testing. So I agree with you. I think that you have to really take it with a pinch of salt if you see very low, especially if you see multiple positives that are very low. That would also make me very wonder whether there was actually a false positive.
Okay. So I should do biopsy. That is what the panel says, and we'll move on to the next case. Yeah, Marlene.
This is a 58-year-old lady from Kerala. She presented to us with right knee pain and swelling, which is progressively increasing and aggravated during evenings. She also had some Zika symptoms. Uh, Her vitals were stable. She had grade 2 clubbing on local examination. Right knee had swelling and mild tenderness. There was bilateral ankle swelling, right more than left, and tenderness, and bilateral crepitation on auscultation. Her total counts were elevated, 14,000 neutrophilic. Her ACE, RA factor, anti-CCP, ANA by IF were negative. CRP was 96, ESR 71, and KL6 1,205. ANA profile was negative. Myositis blood was also negative. Lung function, DLCO was reduced 50%, which increased when we rechecked her after a month to 75%. KCO was 49%, which jumped up to 68%. There was no desaturation in walk test, but walk distance increased by 60 meters the second time we tested her.
Yeah, so these two tests were done in our hospital only, or it was different, right? Or our center
Ma'am,
only?
yes,
Yeah,
ma'am, done here.
our center only. Why we have done? We will see the CT scan and we will let you know. So this was the time when she came to us for the first time, and this was the time after 1 month when we wanted to decide whether we will give treatment or not. Yeah, and this is the X-ray which she was presented with, and this is the X-ray when we did the last spirometry. So with that background, let us Aparna show.
What were her respiratory symptoms, Mirin?
She was admitted.
So
I think
she
she presented to us with this. She came for second opinion, but before coming to us, she was admitted outside with hypoxemic respiratory failure, and she is being treated for some autoimmune disease at another center. I think Dr. Shenoy is treating her for some kind of autoimmune ILD, seronegative arthritis or something. But Shenoy is treating, and she came here for second opinion for ILD part, and this was her CT scan taken outside, sir. This is at the time when she became very sick.
So on this CT was done on 1st of December, and we can see a lot of areas of ground glass and consolidation. Some reticulations are also there, and some of these have this like a perilobula kind of appearance. There is significant involvement of the upper lobes. Lower lobes are also involved, but look like the involvement is little more central, and the extreme bases are relatively spared. There seems to be some mild areas of bronchial dilatation, but there's no honeycombing, there's no other traction bronchiectasis. There were no significant nodes. The esophagus is mildly dilated. Pulmonary artery is within normal limits. So once you told the history about the higher counts and CRP, I was wondering whether this is infection. First, I initially, before hearing the history, I was thinking whether this is like an organizing pneumonia pattern. But after you told the history, I'm thinking whether this could be infection superimposed on whether there is some underlying ILD or not, or whether everything is infection. So whether we should treat as infection first and repeat and see. And I think you also showed the X-ray showing
But you can see
improvement.
features of this thing, na, subpleural sparing, and like, isn't it? Like we can see the pleural line very clear. And actually, when you told esophageal dilatation, I can recall that she had all the features like fish mouth and all the appearance of systemic sclerosis kind of skin features, though she was not antibody positive, and she is being treated for some kind of, I'm not sure what, because but Dr. Shenoy is our rheumatologist who is looking after her for her those problems. And then she presented with this, and we all were that time worried that is it myositis related ILD, because it was, to us also it was looking like OP pattern.
Yeah, that's what I really thought of OP.
Yeah.
But when you told about the high counts and the CRP, I was just thinking whether at least some of it is infection.
Hmm. And we didn't repeat her second CT scan yet because we repeated the X-ray, which was surprisingly clear. So I'm not intending. I have referred her back to Dr. Shidam. We had a conversation, and we both felt that we agree with Aparna also that maybe some viral infection was the culprit that time, or I might be wrong. She is on HCQ. As I told, she was treated as systemic sclerosis, skin predominant, was never having interstitial lung disease, and that time she received prednisolone 30 milligram for a small burst of this, and we can see the improvement her in her spirometry also, like sorry, KCO and DLCO also. Spirometry was not that bad from the beginning. And desaturation, she symptomatically also improved. So my the questions are, um,
So
so in a
when was the respiratory failure,
1 month
Asmita?
before, sir, just November,
But
December,
her
that
lung
time.
function is normal
So that
1
time
month
when she
ago.
came, she received some steroids and she came. And then they were worried about what to do, whether she will require a rituximab and other things and not. So they came for second opinion.
Okay.
Can you show the X-ray again, both?
Yes, sir.
Yeah, and I'm also wondering whether it's the same person's X-ray.
Yeah.
It is, sir. Wow.
It-
But taken at different center, and this must
because
be the like I'm not sure with it was taken not in our hospital. This was outside X-ray, and I did not do X-ray on the first visit, and this is our hospital X-ray, sir. I'm
the
sure.
X-rays do not. I mean, it would definitely raise the doubt if they are the same person, but I'm not
Yeah.
sure.
No,
Both are females. The
no,
clarification
that
more
is
or less
same
similar.
same
The
person,
same
sir.
patient. Yeah.
Same person. You see the avatar and other things, you will feel
Sure,
it is same. And
sure.
maybe it was she was not having that much of inspiratory capacity at the time when it was taken. So this is, I would say, she improved actually. Actually, she improved. I don't know what worked. Maybe short course of steroids or over a period of time. So superimposed viral or
So
bacterial
viral
infection.
infection, organizing
Yeah.
pneumonia.
Yeah.
And does this scenario warrant a repeat HRCT test now, or it can be managed clinically? And how should we differentiate a flare versus infection? That, like, I don't know.
I don't
Yeah.
think I'd repeat a fresh scan with that X-ray and that lung function, but I'd be happy to hear if Athol or Somye or Prahlad would.
Yes, sir. Professor Wells. Yeah.
Just very briefly, so the scan is difficult to classify. The ESR raised infection. The other thing it raised, if you don't have another process and it's fairly diffuse abnormalities, elements of organizing pneumonia, is a form of vasculitis that might respond to therapy. So I'd say your net is cast at this stage. You've probably got a very good response, you're saying, aren't you, at the end of the day? You've got a scan that you're not surprised that quite a bit of this, if it was inflammation rather than infection, would reverse. So you've got a scenario of somebody with quite extensive abnormalities on a scan, a very high ESR, reversibility with therapy, and you really can't be too precise, but the danger would be to miss a vasculitic process. I mean, get a response, but what is going to happen downstream? And I will say that standard autoantibodies looking for vasculitis aren't necessarily going to deliver.
So we can stop steroids and see if it was ongoing process, it should worsen, right?
Yeah, I think the other thing is, I suppose you look at urinary sediment, you just set your net a bit widely. I'm not saying I think it's a vasculitis, but I am saying that the bad diagnosis to miss might turn out to be some form of vasculitis.
Okay. So we don't need to do a CT scan right away. Anybody wants to say anything, or we'll move on to the third case? Yeah.
I actually think you probably should. You've actually probably removed quite a few of the abnormalities. You've got a baseline of where you are following therapy, and it might turn out to be important if you're trying to actually see what then happens downstream and trying to interpret change.
Sure. So now she has gone back to primary consultant and will keep under follow-up, and I will send definitely vasculitis workup. with urine sedimentation. The last case is a simple case, and then we'll move on to SIRS cases. Yeah. Merit.
It's a 47-year-old lady from Kerala who works in the packing section of a seafood company. She's a known case of hypertension and bilateral granulomatous anterior uveitis and small vessel vasculitis of the right eye. At present, she does not have any respiratory complaints. Her vitals were stable, respiratory auscultation was normal. She was anemic. Her routine blood workup was normal. Serum ACE was 31.7, normal. CRP, ESR were within the normal range. Serum calcium was 8.32, MON2 negative.
Echo was also normal. Yeah.
Echo normal.
So she was being treated outside, and then when she came to us, Mithun suggested that this can be sarcoid also. So we did a CT scan. CT scan was not done prior to coming here.
So the images are slightly expiratory in nature, so the lungs are looking slightly higher in density, but otherwise I do not see any nodules. Some mild inhomogeneity is there in the bases, which could be due to this expiratory scan. Coming to the mediastinal window, we do see some small nodes, but they are quite small, and the largest that I saw was subcarinal, which was around 11 millimeters in short axis. Hilar and interlobar also, there are some 8 to 9 millimeter size nodes. Pulmonary artery is not dilated, no RARV dilatation. And in this non-contrast CT, we don't see any lesions in the liver or spleen. They're not enlarged also. So all we have is borderline mediastinal and hilar nodes. No
Right.
significant lung findings.
Yeah. Actually, we did EBUS and we found the same, that the largest lymph node was in subcarinal region. That also not very great, around 1.3 to 1.5 in maximal diameter. And unfortunately, we could not get anything in the rows or even afterwards. So EBUS was inconclusive, to be honest. And then we are nowhere close to any diagnosis. So anybody wants to say anything? Like the questions were, patient is currently on methotrexate and folic acid. So is the CT features suggestive of sarcoidosis or TB, or do we need to prove further, as initial EBUS TBNA came inconclusive? We did only to prove that it is sarcoid, but I could not prove it. So should I do repeat? And they are not even quite affording kind of people, and any other management is required other than methotrexate, which she is already on.
Is there any danger to her lung function, Asmita? Oh.
No, it's fine, sir. I didn't do a walk test and all. She is room at 100%. The only reason was like whether she had thoracic sarcoid also, and there is a eye involvement, anterior uveitis, and she had some slight disturbance in the left eye wherever that anterior uveitis is there,
So then
for
as
which Mithun
per,
is treating.
yeah, and so then as per Athol's rule in sarcoid, you wouldn't
Treat
really
it.
proceed further
Yes, sir.
on anything unless Athol himself has a view on this.
I have certainty because you presented one other feature, and that was small vessel vasculitis. So what you've got is a granulomatous uveitis, and you've got a small vessel vasculitis. And so although sarcoidosis might broadly summarize what this is, and maybe it's a coincidence, there's a small vessel vasculitis, I'd say in this situation, there is a case of simply doing a transbronchial biopsy, establishing you've got sarcoid granulomas in the lungs, and just a caveat that you've got this small vessel vasculitis sitting there, which may not be a coincidence. And so this overlap for sarcoid vasculitis and granulomatous vasculitis is quite tricky. The uveitis is suggestive, but there's this set of patients who do have eye issues that are granulomatous that you never actually establish are more general sarcoid. So you don't have to say that you're going to be 100% certain. All I would say is do what you can easily to see if what you've got in the lung is sarcoid. Accept the uncertainty and just hold the uncertainty, because if the patient's doing well with methotrexate, it just remains to keep that uncertainty in mind if you don't get there to 100%.
Okay, I'll speak to her if she is willing, because even this procedure also she took 3 months to arrange money. It's difficult for her. So
What is a Mantu report in her?
negative.
Negative.
Mento was negative. We did here. But we, as we said, na sir, we were going in the track of sarcoidosis, but sir is suggesting small vessel vasculitis. So I'll send workup for that.
Look, I think the other thing to say is the negative Mantu in a country where people should probably be getting low-grade. It's certainly going with sarcoid. Whether it goes with a granulomatous vasculitis, I have no idea.
Okay.
Yeah, I think
Sir, Madam, Dr. mentioned about transbronchial biopsy. Which will be the area? Because the
so in sarcoidosis, this PGI paper says that you can do from bronchial biopsy and transbronchial from any area. It's in sarcoid, yeah, anywhere. Okay.
In fact, doing all three according to them,
all three,
improves yield.
Improves, yeah. That is what the paper was. Yeah. So we'll move on to Rajan sir's case. The first case we will take the other one, sir, which images are available, and then meanwhile I'll try to get the images.
Sure. I'll just tell Bharat to join if he can.
Yes, sir.
He is just Bharat. You can join if you can. We're just starting. Thanks. No. All are ILD pulmonologists. You're the only oncologist. Yeah. That's why we need you. No. There. Okay, starting presentation. Bye. So I'm just getting our oncologist on the call for this, and thank you, Asmita, for including this lady, 60-year-old from Chhattisgarh, married with 4 children, never smoker, no exposures, no pets, hypertensive, hypothyroid, and diabetic. Overweight, BMI 27.2, sedentary lifestyle. What was surprising was actually that she was well till December 2025 and then started complaining of suddenly dyspnea on minimal exertion, weakness, headaches, occasional cough, and she'd lost 4 kilos in 1 month. No symptoms of autoimmune disease, no family history of lung disease. Her saturations when I saw her were 91% on room air. It was tachycardic, counts were slightly elevated. She's uncontrolled diabetes at that time because she had received some steroids in Chhattisgarh state before coming to Mumbai. Echo was done, mildly elevated pulmonary artery pressure, IVC normal. So when I admitted her, next slide. So we investigated her. I said we got to do her full autoimmune workup. When I saw her scan, everything turned in negative. ESR 45. She was just wasn't possible to perform PFTs. We tried almost for 5 consecutive days, but then because of the scans, if you see the scans which Aparna will pull up, we pulsed her. And we did a baseline 6-minute walk test, 91 to 86 on the 17th of January. And 10 days later, the walk distance was the same, but she started with 95, went down to 91. So definitely better on the saturation front. Next slide. And this was our lung function technician, a very enthusiastic guy. So he said, if he can't do lung function, she can do iOS. And so I'm going to leave it to Prahlad or anyone who understands iOS better in ILD to interpret this. But I couldn't, I don't know whether I should monitor her on iOS in the future. So we'll just keep this aside for the time being. Next slide. And the CTs and PET.
Aparna.
Yeah. So this is a CT from 14th of January. And this start from the top. So what we're seeing is a lot of ground glass opacities, both centrally and peripherally in the upper lobes. They're becoming more confluent as we go down to the lower lobes, and there are just some few lobular areas of sparing, but otherwise it's just confluent ground glass. Some areas are more dense and consolidation. No significant fibrosis. We don't see any reticulations or traction or honeycombing. The mediastinal window, one thing that stands out is one enlarged left axillary node here. Mediastinal nodes are borderline, and there is a lesion in the left breast also. One ill-defined kind of lesion is in the left breast. So mediastinal subcarinal also borderline 9-10 millimeter size nodes are there. There's a small lesion in the liver also here, one hypodense lesion in segment 4 or 8 of the liver. I did not see any skeletal lesions. So the lung findings basically is like NSIP or NSIP-OP overlap kind of pattern with a lot of areas of ground glass density with not much of fibrosis. And we definitely have to evaluate that breast lesion with the axillary adenopathy.
Right. And so, Aparna, we did biopsy that lymph node because the radiologist hadn't reported the breast lesion, but they reported the lymph node.
Okay.
And they said then in retrospect, yes, there is probably a breast lesion. So anyway, we biopsied under ultrasound guidance the lymph node. And do you have the next slide?
1 second, sir.
Yeah.
You okay?
Yeah, and then she can show the PET maybe if but I'm not sure if we
No, I don't have the PET yet.
You don't have the PET? Okay, no
No.
worry. So the lymph node biopsy, the gene expert, the hemi-nested PCR is negative. Cultures are weighted, but the histopath showed a metastatic carcinoma, possibly from the breast. And Bharat is here on the call. He's our oncologist. ERPR negative, HER2 positive, GATA3 positive, GC, whatever all this means. But I then had to get Bharat to help us figure out what the next step is. And so the questions really were, this is fibrotic ILD with a CA breast. Not much fibrosis, as you rightly said. The rheumatology review in the hospital was negative. Clinically, she responded to steroids, and it's just been about less than 3 weeks since we gave her those pulses. And we called the surgeon in who was ready to do the surgery, but then Bharat had a take on not doing surgery first. He said, let's give her trastuzumab, pertuzumab, docetaxel, because the response to chemoimmuno he felt, and he'll correct me if I'm wrong, would tell us about the prognosis, and this would be neoadjuvant and then do the surgery.
Yeah.
So my questions are, what's our working diagnosis on the ILD in such a situation? How do we monitor the chemoimmuno? Because she can't do PFTs. She's just, probably it's literacy or technique. Does iOS help to monitor? So I'd love to hear your thoughts on all this. And in fact, trastuzumab, I was worried when you put it on because we've seen a few ILD cases. But Bharat, you want to comment on why you?
Yeah. So the concern about ILD related to trastuzumab is for trastuzumab deruxtecan or TDM1. They are different molecules. They are basically a combination of chemotherapy with targeted therapy. Their chemotherapy is a payload. It is attached to a HER2 targeted monoclonal antibody. And the mechanism of action is totally different in that. So we label it as an antibody drug conjugate. With trastuzumab and pertuzumab, we haven't seen any patient deteriorating. So what happens? Usually, this HER2 targeted trastuzumab goes and attaches to the HER2 receptor, and it is taken by the particular tumor cells. In trastuzumab deruxtecan, what happens? The drug delivery, the trastuzumab has to go to the HER2 receptor. That is, goes inside the cells and release the chemotherapy drug inside the cells. So for ILD, the mechanism of action for TDXD or TDM is not very clear, but what this the suggestion comes from the scientist. Probably the uptake instead of the HER2 receptor, it happens with the macrophages. Those macrophages take this instead of the HER2, they take this HER2 monoclonal antibody and the payload, that chemotherapy drug is delivered in the macrophages and which selectively causes inflammation in the lungs. That's the mechanism of ILD with trastuzumab one, but it's with trastuzumab deruxtecan or TDM1. Both these drugs are different from trastuzumab or pertuzumab.
Sure.
And the incidence rate is 10 to 20% with drug mortality rate is nearly up to 5%.
That is with trastuzumab deruxtecan.
Yeah, maximum with trastuzumab deruxtecan, and lesser with TDM1.
And you were more worried about the docetaxel, right, for her than
the... So what happens with paclitaxel? We usually, for such patients, consider who is frail, we give weekly paclitaxel. But paclitaxel specifically causes pneumonitis. Right. So I was worried about paclitaxel. That's why I used docetaxel. A better preparation, docetaxel, but docetaxel. And my point was, let's give the drug, see how the patient behaves in one cycle. If there is no deterioration, we can complete the 6 cycles. What happens at the end of 6 cycles? Up to 60 to 70% of these patients, the tumor disappears completely. So you just do a excision of that part and you label them as a pathological CR, pathological complete remission. And those patients, probably we can de-escalate the treatment in the adjuvant setting.
Okay, got it. So that was the purpose of not proceeding with surgery.
So that's the worldwide, that's the standard. If the patient has locally advanced breast cancer, node positive, one should not do the surgery. Because what happens if you do the surgery, anyways, your patient is anyways at risk of anesthetic this thing. So you get time to treat the ILD. You give the chemotherapy, see if the patient tolerates, finish the 6 cycles. By the time, suppose ILD also becomes better, definitely you can do a surgery. But when the burden of disease is less, the surgeon also takes little time. Even they can decide or tailor the surgeries.
Sure.
Limited dissection of the axilla, taking out the So we have done it for elderly patient. You just have taken out the lump under LA also. We have done that because these patients do well. When the tumor disappears completely, we are looking at not doing the surgery in the future. Don't do the surgery. Just give a localized radiation. But that's under research setting now. But in future, surgery will be out for the breast. In next 10 years.
Athol, Sonia, Prahlad?
I have just 2 comments, Sujit, but I wanted to ask a question. How long was her disease severe symptomatically when you snapshotted the scan?
Just a few weeks, 3 to 4 weeks.
All I'll say then about the diagnosis, you're looking at a form of lung injury, I suspect, we should conceptualize OP as subacute injury, as Kevin Leslie also always used to call it. You can give it a label of OP and SIP as most likely, but it's probably a form of acute to subacute injury. You've excluded a myositis, the steroid responsiveness, and you suspect that there is some immune dysregulation driving that, and then you got the response you have with steroids. So this, I think, is best viewed as a form of subacute lung injury at a moment where an exact label probably doesn't much help above that. My only other comment is an instinct. With drug-induced disease, people don't get the disease always the moment they get the drug, and often something else sensitizes the lung to the drug, often an infection. And I would say if you're in the throes of having what is a fairly major injurious process in the lung, whatever drug you use that might have a drug side effect is simply going to be much, much, much higher risk. That's an instinct. I can't prove it. It's one of those arguments, multiple appearances, single unifying mechanisms. So I think your likelihood of drug-induced disease, given at this point, has to go much, much higher, but that's just instinct.
Sure. And monitoring at all? How would you monitor? iOS? No.
I don't like people who are expert in some things who claim to be expert in all things. I simply don't know the answer to the iOS.
Sonia.
I'm right there with Athol. I don't know about iOS. I think that I agree with Athol in the sense that it almost doesn't matter what you call this. I think that it is some sort of inflammatory lung injury. And I think the fact that it's occurred in the context of a new malignancy suggests there may be some association, whether you call it paraneoplastic or not. But I think that you hopefully are going to find out that it either improves with the removal of the tumor, or as Athol also points out, you have a sensitized lung, which makes the lung more at risk of getting an injury. So I think that you don't have a real choice here. I think the idea of giving her targeted therapy is exactly right.
Sure. Prahlad?
Sandeep Salvi sir's lectures, the point was iOS mainly for an obstructive airway disease may be considered as part of checking the response, not too sure about restrictive.
Yeah, I agree with it. I mean, it's just that people are looking at it at restrictive lung disease with the reactants and AX values, right, Prahlad?
That matter is a bit still unclear about that expiratory, inspiratory more than the expiratory. I think still things are not very clear there. I think so. That's what.
Yeah. And so Bharat feels that paraneoplastic is unlikely and rare, and if we control the basic issue. Yeah, Bharat?
Yeah, so those paraneoplastic would be the last on my list. Having said that, I have seen a couple of cases. And the only treatment is you have to get the disease under control. And the way forward is, if the response rate is good, patient is not tolerating, I will be requesting the surgeon to take out the tumor earliest. Patient, we have given only one cycle so far. There are no toxicities. So definitely surgery is the key. You have to take out the antigen out of the body. Then only the paraneoplastic syndrome will under control.
Got it.
And we really have to have the sequential scans, lung scans also.
She's going to come back. She's gone back to Chhattisgarh.
Yes.
She's going to come back.
It's better request the patient to come to us, because the way we are, the team is taking care of this patient as a multidisciplinary. We may not. Having said that, there are no abilities there also. It's better to at least clinically see the patient radiologically. Second thing is, taxanes do cause pneumonitis, but again, as I said, paclitaxel is more than docetaxel. And we also have seen a couple of pneumonitis cases with docetaxel, but it's relatively better. That's why we chose docetaxel.
Right.
But if it turns out to be a paraneoplastic, then it must be one of the few cases anybody has reported in the breast. I have seen in endometrial cancer, very early stage endometrial cancer, paraneoplastic myositis. Presentation was paraneoplastic myositis. There was a case of, again, endometrium with some pneumonitis, but not of breast so far. Paraneoplastic ILDs I have seen.
Thank you, Bharat. We really appreciate your inputs in our ILD group. I have to tell you that I know you've been wanting to start a lung onco MDD, but you don't have an Asmita in your group, which is the sad part. So you don't. He's looking for someone to do that in oncology, and we'll be happy to help you in that group.
We do it routinely in our tumor board, but sir said that it is too much for me to go that also, though I am trying my best to go there. Having said that, I would like to ask one last question. So trastuzumab, the trial drug, I am part of the trial. So in that, we had seen quite a few. Actually, currently also one patient is admitted under me who started on trastuzumab, and almost the same feature. In this patient, it was before starting the drug, and I had seen couple of cases in which before starting drug itself, it was showing ILD. So I had seen enough to say that there is some relation between CA breast and this, because many patients had already baseline PET CT, which was reported as organizing pneumonia or ground glass opacities or many things which were reported prior to starting trastuzumab. So that was not a surprise for me that the patient has two coexisting diseases.
Sure. And that is basically the deruxtecan. I think we have all seen at least one patient with trastuzumab.
That's really, for deruxtecan, you need to do scans after every 2 or 3 cycles.
Yeah.
No, otherwise they present with symptoms. We do scan because they present with symptoms.
TDXT, though, is the best drug in terms of the response and survival, and it's making news in breast cancer now. But those who see the toxicities, ones who actually see the patient very carefully, they end up in seeing the toxicities. Otherwise, what happens? You just prescribe a drug and then patient goes Many times they deteriorate. Nobody looks at it as an ILD, treat as a pneumonitis, sepsis. But now every oncologist knows that ILD is one thing which needs to be carefully monitored for two drugs, TDM1 and TDXD.
Athol?
Just, it may be an obvious point, but it's a patient with inflammatory injury pathways activated. You're giving drugs much more likely to provoke that. You can't give immunosuppression. So I would say thinking about, for once, too much steroid in other settings. When you're covering a period, if you're giving a drug with a risk of lung injury, you might want to be thinking about holding on to more steroid in the background.
I've got it down to 20 milligrams a day. You would probably want to get it off ASAP, Athol, once she gets back?
No, what I'm really saying here is I do think if you're going to give a drug which has a risk of causing drug-induced injury and you're in this setting, then for once you might be wanting to say, be a bit careful about withdrawing the steroid.
Yeah,
sure.
So for docetaxel, go ahead.
Because you can't use immunosuppression in this setting, I understand that. So what else have you got actually to protect what could be a fatal drug reaction? And that is what I would suggest.
Got it. Yeah. Bharat, you were saying something?
Yeah, so mentioning about the steroid as a prophylactic. So for docetaxel, we use 2 days of steroids, but that purpose is not for ILD. We use it to prevent the drug-dependent edema and the skin toxicities. So we use post-docetaxel 2 days of steroids, and 1 day prior we give Dexa. Because this drug is notorious to cause skin-related toxicities, but its basically purpose is not to address the ILD issue. For trastuzumab deruxtecan and TDM1, so far we have not been using steroids. As I mentioned, the drug is delivered in a way it causes a bystander effect. So if it is taken up by the macrophages, it is released in the nearby cells, which again maybe pneumocytes or the lung tissue, and it causes something called as a bystander effect. So that actually leads to ILD. And it needs to be picked up at early stages. The drug should be stopped, held for 2 or 3 cycles, or it should be stopped if the ILD is of higher grade. And the number of actually grade 1 or grade 2 toxicities, which are milder toxicities, is up to 20%. Means out of 120%, 20 people are developing ILD with that, irrespective of the age. Obviously, smokers, those patients who have received radiation beforehand are at higher risk. Because lung get exposed to the chest wall radiation. So that is also one of the risk factor.
Thanks, Bharat. Thank you.
Sujit, can I just add, your
Murli,
question
please,
on the iOS?
Yes, Murli, please.
It's not great for monitoring. It's great for making a diagnosis, even of the restrictive patterns.
Right.
But not great from the monitoring point of view. The results are just too fuzzy. I was just going to suggest, why don't you try doing her spirometry again and her 6-minute walk as she improves? And if she's been able to do it now, that would actually be pretty helpful.
So I was thinking exactly, Murli, I was thinking of getting a scan done at about 2 months earliest, and then probably get a 6-minute walk as well. But because people have been using the iOS for post-lung transplant rejection monitoring, I thought of whether it could be usful. That's the only reason I put that question.
So we're using that mainly for the small airways disease.
Sure. Sorry about that announcement in the hospital. Okay. Now,
Sujit, can I encourage you to actually find out what iOS does give you here, because it's nice observation which might actually fuel better understanding of its role.
Yes. In fact, I was thinking we should monitor her on iOS as well and see if anything is changing. I had a colleague who does a lot of it, and as Tridip was saying, he's looking at reactants in terms of monitoring, and yes, I want to research that better. Absolutely. So this case actually, I know Prahlad and I have both seen this lady, but the problem is her imaging, Prahlad, from the center where she's been imaged just can't be uploaded to Aparna. Aparna, impossible, right?
Yeah, I am not able to open. Dr. Asmita just said she'll try to open if
She's
she's
trying
able
to
to.
open. But anyway, I'll give you the history and maybe next time we can start with this case with the imaging. But she's a retired hand embroidery worker, married with one daughter. She fed pigeons till 2015. Hypothyroid, hiatal hernia, last endoscopy 2012, but has been complaining of dyspnea on bending forwards since 2012, on climbing stairs since 2019, and the last 4 months, even on bathing, changing clothes, have been a challenge. So it's gradually increasing. Bilateral inspiratory squeaks, no history of autoimmune disease, physio and exercise at home. And she's had a mother, uncle, aunt, asthmatic, no family history of ILD. Now her rheumatology, when she saw Prabhu Desai, Prahlad, her pigeon antigens were positive, ANA 1 in 320 centromere pattern, myoblot, the MDA5 was 2+, VD glucan more than 3.5. Because of her CT pattern, which I wish we could pull up those images, but hemoglobin 13, and that was her echo. Next slide.
Yeah.
And I think Prahlad had kept her on MMF 360 twice a day. I mean, she was on 360 twice a day for 9 months and a little bit of prednisolone. I forget, I hadn't got that dose down. Next slide. And so we sent, this was her lung function of January last year. And as you can see, it's about 50 to 60% predicted, and it had dropped further in December. DLCO is down, KCO down. Next slide. And the CTs, Asmita is trying to pull up. The next slide. And we did an ANA profile. The ANA blot was negative, and the myositis blot showed up a 2+ MDA5. And then we did a scleroderma blot as well, which our lab does. That next slide. That was scleroderma blot was negative. And so the questions on her, because she had this CT pattern, next slide. And yeah, so Prahlad had done a bronch on her 2 days ago. Gene expert negative, KOH negative, galactomannan negative. And Prahlad, I think the PJP was positive, you said.
Yeah, I think she was taking mycophenolate and steroid,
Yeah.
and she had a short history of fever also. That's why I thought, let's do all these markers, and beta D glucon was 3.6, was much higher. So BAL shows BAL was neutrophilic, 66%. Eosinophils was around 8%, 6 to 8%. And I don't have the results like this, but they
they could open the scan, so that's great.
Yeah, and PCP was by immunofluorescence was positive.
So, Aparna, I will just scroll the images. This is the only image which I can open. But
What's the date?
I'll start from the beginning, okay? And you start talking.
This is the latest scan before, I think, Prahlad, you bronked her, right? Yeah.
First I'll scroll and then we'll scroll slowly, okay? Because you have not seen the images. You are able to see, right, Aparna? Aparna?
Yeah, I can see what you're sharing. Sorry, I was muted.
Yeah. So, Aparna, this was the latest scan before which Prahlad, just after which Prahlad scoped her.
Okay.
Because the BD glucan, galactomannan, BD glucan in the blood was high. So he scooped her because you don't want to up the immunosuppression because of that. And so, yeah, so this was because she was on mycophenolate steroids. You obviously want to get infection out of the way, and then If MDA5 is 2+ positive, the other concern was you need probably triple immunosuppression. I discussed it with Prahlad. She saw me and Prahlad. And so Prahlad, what would now if PJP is positive, I guess you'd start PJP treatment, right?
Yes.
What would you do about immunosuppression? I think that's the real tricky question, correct?
Correct. I think
Sonia, Athol, do you have a view here, Murli, on immunosuppression? MDA5 positive, PJP positive now. It's quite a difficult situation.
You asked Sonia first.
Okay.
I think that you need to have immunosuppression when you're treating pneumocystis anyways to diminish the amount of inflammatory injury. So I think that maintaining steroids is certainly reasonable. Whether you would continue the patient on MMF at this point in time, I think is more stylistic than kind of clearly defined by data. But I agree with you that you want to treat her first. And our experience has been that patients who have myositis-associated ILD have an extremely increased risk of developing pneumocystis, even if they're off of prophylaxis for very, very short times, as much as 4 weeks, as little as 4 weeks. So I think that the idea of treating for pneumocystis is very reasonable. And unfortunately, it's very possible she'll get worse as you start to treat her for the pneumocystis. So I think just kind of, making sure she's adequately immunosuppressed for the inflammatory injury after she's treated.
And then after you finish treating her, Sonia, would you continue to give pneumocystis prophylaxis to her continuously?
Oh, absolutely. Yeah. I think that, this is one group. There are certain subsets of patients with autoimmune disease who have a higher risk of developing pneumocystis, and clearly the patients who have myositis are one of those groups.
So once we finish PJP treatment, you would start tacrolimus with the mycophenolate maybe, or would you give her rituximab? What would be your choice here?
I think that it's going to depend a little bit on how she recovers from the pneumocystis. If she gets better from the pneumocystis, I think you could use tacro. Rituximab obviously has its own risks associated with it. So I think it is going to be a little bit of a question of how much injury she has after she's treated for her pneumocystis.
So you suspect that if she's not getting better, it's probably the myositis that is worsening her then. Got it. And then go to Ritux. Okay.
So how long you will wait, Sonia? How long you will wait? 3 weeks Septron or more than that?
So as long as she's getting steroids, she's getting treated really for both. And so I would probably treat her. I mean, I don't even think you have to wait 4 weeks. I think that you have a pretty good sense after, 2 weeks, whether she's turned the corner in terms of her pneumocystis. And you can then sort of intensify your immunosuppression. And Athol, what are your thoughts?
Oh, look, I completely agree with the management comments. And I was just going to add one thought. For clarity of thought, we like to say one trigger, one cause, but in life and medicine, it's often a combination. And this business of HP autoimmunity overlap continues to puzzle me. Now, you've got a patient here with inspiratory squawks. If you're questioning whether feeding the birds is a plausible trigger, well, her immune system thinks it is, because her immune system is saying, I'm recognizing a trigger. So then, what do you say about what the entity you're dealing with is? I agree entirely with the management of whatever we're calling this, but to what extent an external trigger and to what extent autoimmunity is coming together to drive this, I don't know the answer. That's all I've got to say.
Prahlad?
I feel she had a very strong exposure to pigeons, and she was feeding her pigeons antibodies strongly positive. And that's why somebody has started on steroids and mycophenolate.
Sure.
The only issue is that there's a MAD5. Does it give such a picture on scan, or it is much more fulminant interstitial lung disease you get?
Aparna, if you can just give a comment.
It starts off and then just gallops in whatever I've seen, which is the worrying part actually.
It could be that, Suji, but you think about 2 contributors to this and a scan that isn't at this point classic for that problem. So it could be. The trouble is, you can find pathways whereby if you've got an autoimmune disease, you have the predilection for HP. I reckon you could find an argument that if you've got HP, and we know there's a lot of autoimmune phenomena systemically in HP, that there might be a pathway to getting CTD. I don't think we really have any idea how this will actually evolve, and I'm not sure we will know at this point what we end up calling this with behavior on CT downstream. But the point is, what Sonia says about managing this is going to deal with whatever combination.
Sure. I think we should bring her back to MDD after a month, after you finish the PCP treatment. Maybe we repeat it.
Instead of continuing mycophenolate, steroids and Bactrim DS full dose, if we give, if she tolerates, and then we repeat a scan and see how much clinical improvement is there. Then probably we'll take a call regarding
if we get the time to do that. But my biggest worry in such patients, this PJP, there's MDA5, they suddenly get worse. And I think we just need to counsel the daughter on that, who's quite worried about what all is going on. And she needs to know that this can really move fast.
So can I ask a couple of questions? The first is, did she have two separate diseases? So she had something for which she was getting MMF and steroids, and that actually blunted the second disease, which is MDA5 driven. Is that one possibility? And the second is, no, I've forgotten the second. So let's just go with the first one.
I think your question is a really good one. And I think that what perhaps Athol was saying earlier is that although we think of autoimmunity as being an immune dysregulation, hypersensitivity pneumonitis is as well, because clearly it's the inappropriate response to a non-threatening trigger. And so it doesn't surprise me that you could see combinations of hypersensitivity and autoimmunity, because it just speaks to a more pervasive immune dysfunction. But I don't have any data to support that. That's just sort of my thinking about it.
And the second question I remembered, would you use intravenous immunoglobulin in this patient when you're worried about the combination of infection and you want to give her immunosuppression? Would that be an option?
I think that's certainly an option. And if it is available to her and she can get that medication, it certainly is less immunosuppressive. It's not directly effective against pneumocystis. So I think that, but I think your point is a good one. If you're trying to immunomodulate her without classically immunosuppressing her, IVIG is a very reasonable idea.
Yeah, I think that's a good point, Prahlad, because I think it would help from both aspects. Yeah, preventing infection and myositis ILD.
Okay.
I think that's it.
Great.
We finished
on
cases.
Time.
Yeah.
Despite the audit. Thank you very much.
Thank you.
Thank you.
Yeah.
Thanks, Asmita.
Yeah, next meeting will be on 28th of February, 2025.
Super.
Thank you.
Thanks, everybody. Bye-bye.
Thank you.
Thank you.
That was great. About the only thing is I was a bit worried that Bhavan was silent. I thought he must have had a stroke or something, but then I realized he left.
Oh, gosh.
No, he came only for audit and because we sent him invite for the second year anniversary.
He came for his second anniversary with all of us.
Yeah, because it was he with whom we started and he was the only radiologist, and then we got Vimal Raj sir, and then we got thankfully Aparna. So now they are rotating, but when we started, he was the only one. That is why.
Do you pass my comment on to Bhavan with my compliments?
Yes, I will. He's going to have a good laugh at that one.
Thank you all.
Thank you.
Thank you, Asmita. Bye.
Thank you. Bye.